It's 2 a.m. Your pager goes off. Hey doc, sepsis alert on room 404. Temperature 38.4, heart rate 108. And right there, in that moment, one of two dangerous things usually happen. The first resident panics. 30 minutes later, they've ordered the entire sepsis bundle, given 2 liters of fluids to an 80-year-old with borderline heart failure, drawn cultures from everywhere, and started broad-spectrum antibiotics on a patient who never had sepsis in the first place. The second resident ignores it. It's just another sepsis alert. They roll over, go back to sleep, and 4 hours later, the patient is in septic shock. Both residents made the same mistake. They let the alert make the decisions for them. A sepsis alert is one of the most common overnight pages you will get. It's also one of the easiest to get wrong. Today, I will show you the 6 mistakes I still see residents make and the exact framework I use to decide what to do in the first 30 minutes after a sepsis alert. Let's get into it. Mistake number 1, confusing a screening tool as a diagnosis. The sepsis alert on your pager is not a diagnosis, it's a screening tool. Different hospitals use different screening systems, but they all have the same goal: identify patients who might have sepsis early enough for us to intervene. The problem is that these tools prioritize sensitivity over specificity. They are designed to catch as many potentially septic patients as possible, which means they also catch many patients who are not septic. When the EHR screams sepsis alert because a patient has a heart rate of 108 and a temperature of 38.4, it is simply telling you that this patient has an inflammatory response that could be sepsis, but it could be alcohol withdrawal, for example, post-operative inflammation, or something else entirely. The mistake is letting the algorithm think for you. The alert should start your evaluation, not end it. The first question is simple: does this patient have an infection? That answer requires a quick chart review and a bedside assessment. Look for localizing symptoms and signs that could indicate infections: cough, dysuria, abdominal pain, erythema, wound changes, indwelling devices, infections or signs of infections around them, new oxygen requirements. If after your evaluation you do not suspect an infection, then stop calling it sepsis. Document your reasoning and continue looking for the real cause of the alert. And that brings me to mistake number 2. Before we move on, if you are someone who takes overnight calls, my Substack is where I post the written versions of these 2 a.m. medicine frameworks along with additional practical peers that don't make it into the videos. The link to subscribe to my Substack page and newsletter is below. Let's move to mistake number 2. Assuming infection is sepsis. Not every infection is sepsis. I'm sure you agree with that. A patient can have pneumonia, cellulitis, pyelonephritis and still not have sepsis. Infections alone is not enough. The next question is this infection causing organ dysfunction? At 2 a.m., I don't start by calculating a perfect SOFA score, sequential organ failure assessment score. I start by asking this: is the patient hypotensive? Is the patient confused? Is the patient requiring more oxygen? Is the patient producing less urine? Does the patient really look sick to you? These bedside findings often tell me more in the first few minutes than any calculator. Formally, as you probably most of you know, sepsis is defined as an infection or a suspected one plus acute organ dysfunction, usually represented by an increase in SOFA score of at least 2 points from baseline. Remember, from baseline. But don't let the pursuit of a perfect SOFA score delay treatment. If the patient has a suspected infection and obvious new organ dysfunction, you already have enough information to start acting. If the diagnosis remains unclear, then continue gathering data, including platelet counts, creatinine, and bilirubin, while closely monitoring the patient. The key point here is simple: an infection becomes sepsis when it causes organ dysfunction. In the real world settings, however, I don't always wait for organ dysfunction to be fully established. If organ dysfunction is developing or I strongly suspect it's imminent, I activate the sepsis bundle and start treatment early. And this brings me to mistake number 3, getting fluids wrong. One of the most common mistakes after diagnosis sepsis is assuming that every septic patient automatically needs 30 ml per kg of fluids. They don't. Fluid resuscitation is for patients with sepsis-induced hypoperfusion. So logically, the next question is this patient actually hypoperfused? You cannot answer that question from the chart. You cannot answer that questions over the phone. You need to see and examine the patient. And sometimes the answer is obvious. The patient looks shocky, they are cold, clammy, confused, hypotensive, and clearly unwell. But often the signs are more subtle. When I walk into the patient room, I look for MAP less than 65 mm Hg, or blood pressure significantly below baseline compared to baseline, new confusions or worsening mental status, capillary refill time greater than 3 seconds, low urine output if it's measured or monitored, elevated lactate, and a generally ill-appearing patient. There is no single finding here that proves hypoperfusion. The goal is to put the entire clinical picture together. If there is a suspected infection and evidence of hypoperfusions, start fluid resuscitation promptly. Give fluids in smaller boluses, 250 to 500 cc, and reassess after each one. Balanced crystalloids are preferred over normal saline. Don't hang the entire volume and disappear. And we will come back to this mistake later, because one of the biggest errors in sepsis management is not starting the bundle. It's assuming the job is done once you've started it. Let's move to mistake number 4, missing the already treated patients. The sepsis alert was triggered before starting another sepsis workup. Find out whether this patient was already diagnosed with sepsis earlier during the hospitalization and has already received the initial bundle: fluid, cultures, and antibiotics. One of the most common overnight mistakes is treating every sepsis alert as a brand new event. Many alerts are triggered repeatedly because the patient still has fever, tachycardia, leukocytosis, or an elevated lactate despite already being recognized and treated. In these patients, there is usually no need to reactivate the sepsis protocol, repeat cultures, or automatically give another 30 ml per kg fluid bolus. The first question here is simple. Am I dealing with a new sepsis patient or an existing sepsis patient? If the patient was already diagnosed and treated, your role changes here. Instead of initiating another sepsis workup, determine where they are in their clinical course. Ask the following: is the patient improving, stable, or worsening? Are antibiotics appropriate for the suspected or confirmed source? Have culture results returned that should change management? Has source control been achieved? This is very important. If a patient who had been improving is now acutely decompensating, consider a new infection, inadequate source control, resistant organisms, or an alternative diagnosis. In that situation, a repeat sepsis evaluation may be appropriate. Your job at 2 a.m. is often not to diagnose sepsis again. It is to recognize when an existing sepsis patient is not following the expected trajectory. Let's move to mistake number 5, getting antibiotic spectrum wrong. You've decided the patient has sepsis. You've assessed the patient for hypoperfusion. You've determined whether this is a new sepsis patient or someone already being treated. Now comes one of the most important decisions of night. What antibiotics should I start? One of the biggest mistakes I see is assuming that every septic patient needs vancomycin plus piperacillin/tazobactam. Broad spectrum does not mean give everything to everyone. The goal is not the broadest regimen possible. The goal is appropriate coverage for the most likely pathogens. The first question is, what is the source? Because source determines spectrum. Community-acquired pneumonia, cellulitis, pyelonephritis, cholangitis, neutropenic fever, and an infected pressure ulcer all requires different antibiotic strategies. And the second question is, does the patient have risk factors for resistant organisms? So think about previous culture results. You must look up previous culture results. Recent antibiotics exposure, recent hospitalization, residence in a nursing facility, known MRSA colonization, prior ESBL or resistant gram-negative infections, and immunocompromised state. These factors often matter more than the sepsis alert itself. For example, a patient presenting from home with community-acquired pneumonia and no resistant organisms risk factors usually does not need meropenem, right? On the other hand, septic shock in a patient with a history of ESBL bacteremia is a very different situation. Likewise, not every patient with sepsis requires MRSA coverage. Another common mistake is forgetting that antibiotics timing and antibiotic choices are not the same thing. Yes, antibiotics should be started promptly once sepsis is recognized, but taking an extra few minutes to review prior cultures, identify the source, and select the most appropriate regimen is usually time well spent. At 2 a.m., don't ask what's the broadest antibiotic I can give. Instead, ask what organisms am I trying to cover. The best antibiotic regimen is not the broadest one, it is the one that reliably covers the most likely pathogens while avoiding unnecessary spectrum. Let's move to the final mistake number 6, thinking the job ends after ordering the bundle. You've recognized sepsis, you've assessed for hypoperfusion, you've selected antibiotics, you've ordered cultures, lactate, fluids, and antibiotics, the sepsis bundle is underway. Now comes one of the most dangerous mistakes in sepsis management. Thinking the job is done. The sepsis bundle is not the treatment. The sepsis bundle is the beginning of the treatment. A septic patient can improve, deteriorate, or declare a completely different diagnosis over the next few hours. That's why reassessment is just as important as the initial evaluation. In general, reassess the patient within the first 1 to 3 hours after initiating treatment, and sooner if the patient is unstable. When you reassess, ask as deemed appropriate the following questions. Has the blood pressure improved? Is the MAP now above 65 mm Hg? Has mental status improved? Is urine output improving? Has capillary fill time improved? Is the oxygen requirement stable, improving, or worsening? If the initial lactate was elevated, trend it. In many patients, repeating lactate within 2 to 4 hours is reasonable. A falling lactate is reassuring in these patients. A persistently elevated or rising lactate should prompt reassessment of perfusion, source control, and treatment adequacy. Another common mistake is assuming that a patient needs more fluid simply because the lactate remains elevated. Not every septic patient needs fluids after fluids after fluids. The initial 30 ml per kg is a starting point for patients with hypoperfusion, not a lifelong commitment. After the initial resuscitations, additional fluid administration should be individualized based on the patient's clinical response. Continuing to bolus a patient who is no longer fluid responsive may cause harm. If hypotension or signs of hypoperfusion persist despite initial fluid resuscitation, it may be time to escalate care. Consider ICU transfer and vasopressor support rather than repeatedly administering more fluid. Just as important, reassess your original diagnosis. Do we have the right source? Do we have the right antibiotics? Has source control been achieved? Could this be something other than sepsis? At 2 a.m., ordering the bundle is easy. The real skill is recognizing when the patient is getting better, when the patient is getting worse, and when the plan needs to change. And finally, don't forget to document your assessment, your interventions, and the patient response. Your notes should tell the story: why sepsis was suspected, what evidence of organ dysfunction or hypoperfusion was present, what treatment was initiated, how the patient responded, and what the next steps will be if the patient improves or deteriorates. So the sepsis alert may have started the evaluation, but your responsibility does not end when the orders are signed. In the end, if you found this helpful, subscribe to the channel, and if you prefer reading over watching, I post written breakdowns, frameworks, and the 2 a.m. medicine series on my Substack. The link is in the description field. Thanks for watching, and I'll see you in the next episode of 2 a.m. Medicine.